Hi everyone, and let us start endocrine pharmacology. And the first topic, what we are going to discuss is hypothalamus pituitary hormones. Now, in endocrinology, it is mainly the replacement use because when the hormones are deficient, we are going to supplement to the patient. So, we are replacing it. So, in this topic, we'll be discussing what are the important hypothalamus hormones and what are the preparation and where do we use them. So, we all know that hypothalamus. So, let us understand what does hypothalamus secrete. We know that hypothalamus secrete almost all the releasing hormones. For example, growth hormone releasing hormone, then gonadotropin releasing hormone, then cortisol releasing hormone, then thyrotropin releasing hormones. So, mainly the releasing hormones. Apart from that, hypothalamus also secretes oxytocin and another hormone, and that is called antidiuretic hormone. Antidiuretic hormone is called by one more name vasopressin, and we have discussed that extensively in antidiuretics. Now, hypothalamus controls the activity of pituitary. Now, there are certain hormones released from pituitary. What are those? They are nothing but growth hormone, then prolactin. So, the growth hormone, prolactin, then the LH, FSH, then we have thyroid stimulating hormone, then ACTH, adrenocorticotropic hormone. These are the major hormones from the pituitary, that is growth hormone, prolactin, LSH, LH, FSH, TSH, and ACTH. Now, hypothalamus also secrete one more hormone that is called growth hormone, inhibitory hormone, and what we also call it as, what is the other name for that? Somatostatin. And also we have prolactin inhibitory hormone. It is also called as dopamine. So we will be discussing first the concept regarding growth hormone. Then we'll be discussing the concept regarding growth hormone inhibitory hormone, then prolactin inhibitory hormone, then GnRH, then oxytocin. Now, these are the concepts which we are going to discuss, and others are not so much important because the growth hormone preparation will be discussing, and whatever important in that we'll be discussing. But whatever we are going to discuss now, they are most important for your exams. ADH, I told you, we have discussed already in the antidiuretic topic. So let us start our journey. I will start with the concept regarding growth hormone and its related drugs. So it's like a flow chart. Let us start from the flow chart. So we have the growth hormone releasing hormone. Now there is a preparation of growth hormone releasing hormone that is called sermorelin, and one more is called hexamorelin. So the preparation of growth hormone releasing hormone, that is sermorelin and hexamorelin, we are not using them nowadays. One more preparation of growth hormone releasing hormone, that is called tesamorelin. So it is called as tesamorelin. And where to use tesamorelin? It is used in HIV associated. So when we treat HIV patient, they will develop certain condition called lipodystrophy. So for that, the drug approved is tesamorelin. Sir, do we use tesamorelin for growth hormone deficiency? No. It is only approved for HIV associated lipodystrophy condition, that is growth hormone releasing hormone. Now this growth hormone releasing hormone acts on pituitary and there is release of growth hormone. Sir, is there any preparation of growth hormone? Yes, the name is called somatropin and one more is called somatropin. So these are growth hormone preparations. Now where do we use them? Where do we use growth hormone preparation? Obviously when there is growth hormone deficiency. So when the growth hormone is not working or not coming out. So growth hormone is deficiency. Second, short stature. If the child is not gaining height, and certain syndromes called the Turner syndrome, Noonan syndromes. So where the height has to be increased, so these conditions we use growth hormone. The name is somatropin and somatropin. Now this growth hormone will act on the receptor called growth hormone receptor. So let me write a cell for you. So in this cell, we have the growth hormone receptor. Now, can you correlate here general pharma? Growth hormone acts on which receptor? Is it tyrosine kinase or JAK-STAT? So growth hormone receptors are JAK-STAT. So growth hormone receptors are JAK-STAT. Now, growth hormone receptor will release a factor called insulin-like growth factor 1. So when the growth hormone receptor acts on the cell, it releases insulin-like growth factor 1. Now many a times we use the recombinant form of this. The recombinant form of insulin-like growth factor, the name of it is called mecasermin. Now mecasermin is a recombinant form of insulin-like growth factor 1. Now can you correlate general pharma? On what receptor insulin-like growth factor 1 works on? Is it tyrosine kinase or is it JAK-STAT? Obviously, growth factor means tyrosine kinase, growth hormone means JAK-STAT. Now, where do I use it? Problem is sometimes growth hormone is released from the pituitary, but the receptors are mutated or the body is producing antibodies to that. Then we use the drug mecasermin. So, mecasermin is used whenever there is growth hormone receptor antibodies. Growth hormone receptor antibodies or the growth hormone receptors have become mutated. So in that cases, we have to use insulin growth factor. Later, we came with one more group of drug that is a combination of insulin growth factor 1 and the binding protein. So what is it called as? It is called as mecasermin. It is called as mecasermin rinfabate. So it is a combination of two, insulin growth factor 1 and its binding protein, which is called mecasermin rinfabate. And where do we use it? Uses. Now this is used number one, HIV associated adipose redistribution syndrome. Adipose redistribution syndrome. Yeah, there it is used. Second important, it is used in severe muscle dystrophy. Severe muscle dystrophy, we use this drug. And next important, it is also being used in severe insulin resistance cases. So the name of the drug is mecasermin rinfabate. So guys, these things we are given in flowchart. You can just follow this. See, GHRH analogs are sermorelin and hexamorelin. Now we are not using it anywhere, but only drug that is used is tesamorelin. It is used for HIV associated lipodystrophy. So the growth hormone preparations are somatropin and somatropin. They are used in growth hormone deficiency, any idiopathic short stature, Turner and Noonan syndromes. Then many a times growth hormone receptors, they develop autoantibodies or they will have mutation. Then they release insulin growth factor 1. So what we do is, if there is antibody or mutation, we have to give insulin growth factor 1, and the recombinant form is called mecasermin. And we use it in a patient has growth hormone receptor antibodies and mutations. Now we have one more preparation, which is a combination of binding protein and IGF-1, that is called mecasermin rinfabate. Moving on to another important growth hormone concept they will ask in the exam is the drugs used for managing acromegaly. So this is very commonly asked, what are the drugs we use to manage acromegaly? Now you know that acromegaly is a condition where the growth hormone is excess. What are the therapies we have for that? Number one, we have growth hormone receptor antagonist. We have growth hormone receptor antagonist. And we know that growth hormone inhibitory hormone is nothing but somatostatin. So we have somatostatin analogs. and we have certain things called D2 agonist. So we have three modalities of treatment for acromegaly. And what is it? The growth hormone receptor antagonist is called as pegvisomant. It is called as pegvisomant. You read the name, soma antagonist. Soma means body, antagonist. So growth hormone antagonist. And remember, if it is added peg, peg stands for polyethylene glycol, and that makes the drug longer acting. VI, you can remember, the drug can produce vision impairment. It can produce vision impairment. The name is pegvisomant. So recently this question was asked in the INSCT pattern of exam. Somatostatin analog which are being used are octreotide, lanreotide, and a drug called pasreotide. Now D2 agonists which are used are bromocriptine. The name is bromocriptine, and one more drug is called cabergoline. So we have bromocriptine and one more drug is cabergoline. So management of acromegaly, drug therapy, we have three modalities: growth hormone receptor antagonist, somatostatin analog, and D2 agonist. So once we have understood the growth hormone concept, it's important that we understand the growth hormone inhibitory hormone, and it is also called as somatostatin. So it is also called as somatostatin. Now, somatostatin is shorter acting. Remember, any endogenous substance are shorter acting. So what we do is we use the analog of this. The analog of this is called octreotide. The name is octreotide, and octreotide is 40 times potent compared to somatostatin. It is 40 times potent. Now, the questions will be asked mainly on the octreotide, where to use it, and let us understand the concept here. Octreotide, remember, it's like somatostatin. So whatever somatostatin does, octreotide will do that. So obviously it decreases the growth hormone. So which condition I can use it? Just now we discussed that it is used for acromegaly. It is used for acromegaly. Second important thing, understand somatostatin, it can cause vasoconstriction. So because it causes vasoconstriction, we use it in a condition where it is vasodilated, and the condition is called esophageal varices. We use the drug octreotide. So we use the drug octreotide. Can you tell me other drugs used for this? So we use another drug called terlipressin. Terlipressin is V1 selective drug used for esophageal varices. Can you tell me a beta blocker used for prophylaxis in portal hypertension? And that is called propranolol. So these are the other correlation we are getting here. Terlipressin is also used for the condition called esophageal varices. For prophylaxis, we use propranolol. Now moving on to the other important aspect, when we discuss this, we know that somatostatin is also secreted in the pancreas, and it decreases the release of insulin. It decreases the release of glucagon. So since it decreases the activity of insulin glucagon, can you tell me where we can use it? Obviously, where we want to suppress insulin, condition called insulinoma. Now, if it suppresses insulin, what is the risk for the patient? Guess what disease the patient can get? Obviously, diabetes. It is also used for treating a condition called glucagonoma. Right. Now, moving on to another important use of this octreotide. Octreotide is used because it decreases intestinal secretions. It is known to decrease intestinal secretions, and that's the reason it is used to treat mainly secretory diarrheas. So it is used to treat secretory diarrhea, and also we see diarrhea in certain conditions like VIPoma. and carcinoid syndrome. So these are the conditions where we see diarrhea and we use octreotide. So basically you should understand octreotide is used for acromegaly, esophageal varices, insulinoma and glucagonoma, and in diarrhea condition, particularly secretory diarrhea. So in most of the exam they will ask you whether it is used in blood diarrhea. No. And remember, it's a tide, so it is not given orally. Now, there are certain additional uses of octreotide. It's a higher learning. Other uses of octreotide. Number one, it is used as an antidote for sulfonylurea, induced hypoglycemia. So when the sulfonylureas are used, and you know that they are hypoglycemic agent, and to overcome that we use this drug. Second, it is also used in a scan called octreoscan. Now octreoscan is a scan which is used to detect neuroendocrine tumors. Detection. And it is also used to treat thyrotrope adenoma. So now thyrotrope adenoma is operable. Suppose if it is not operable, that is called inoperable cases, then we use octreotide. So basically these are additional uses you have to remember. Otherwise the basic concept is acromegaly, esophageal varices, insulinoma, glucagonoma and diarrhea. Now when we know this drug octreotide, what is the adverse effect? The adverse effect, obviously, when it decreases insulin, there is an increased risk of diabetes. Second, it has shown to increase the risk of gallstones. And number three, it also has caused vitamin B12 deficiency. So, in somatostatin analog, do you think we have only octreotide? Is there anything else? Yes, we have a drug by the name lanreotide. So lanreotide is used for neuroendocrine tumor. So treatment of neuroendocrine tumors. And it is also used to treat acromegaly. Lanreotide. So we have another drug, pasreotide. Now the pasreotide is also approved to manage acromegaly. It is also used on one more condition, that is Cushing's disease. So Cushing's disease. So please take the message. All the tides, octreotide, lanreotide, pasreotide, all are used for acromegaly. Lanreotide as a specialty, it is used in neuroendocrine tumors. Pasreotide as specialty, it is used in Cushing disease. So that is about the growth hormone, inhibitory hormone, somatostatin, and the main drug in that is octreotide. So once we are done with that, let us move on to another important concept, the prolactin inhibitory hormone. So prolactin inhibitory hormone is nothing but the dopamine. So prolactin inhibitory hormone is nothing but dopamine. So why are we studying this? Now, prolactin inhibitory hormone is dopamine. That means it decreases the activity of prolactin. What happens if prolactin is high? Prolactin, if it is high, it can cause galactorrhea. It can cause infertility in reproductive age group. So we cannot give dopamine to suppress prolactin because dopamine cannot cross blood-brain barrier. So we use something called D2 agonist. So we use D2 agonist for that purpose. So there are two important drugs in that category. One is called bromocriptine. So remember the name, bromocriptine. And one more drug is called cabergoline. So B and C, bromocriptine and cabergoline, these are derived from ergots. And we have one more drug which is non-ergot, and the name is quinagolide. Quinagolide. But remember, the most important drugs you to remember is bromocriptine and cabergoline. Never forget them. In both of them, the longer acting is cabergoline. Cabergoline is longer acting compared to bromocriptine. Now, where do I use it? You know that they suppress prolactin. So, what is the tumor where prolactin is secreted? Number one, it is used in prolactinoma. Now, what is the problem if prolactin is high? So, that is called any hyperprolactinemia condition. Any hyperprolactinemia condition, we can use it to suppress the prolactin activity. Number three, if prolactin is high, what happens? Now, this will lead to infertility. If prolactin is high, it will lead to infertility. What happens if prolactin levels are high? If prolactin levels are high, what happens is they decrease the activity of LH, and that decreases ovulation. So, suppose a reproductive age group woman, she is married and she is not able to conceive. She is not able to get pregnant, and she comes to you. And if you do the prolactin investigation, if prolactin levels are high, then you can give these drugs to suppress prolactin. Otherwise, in that woman, if prolactin is high, the LH surge will not occur, the ovulation will not occur, and she will have infertility. So remember this point very carefully. If prolactin is high, she is not conceiving, you have to suppress the prolactin activity. Another important thing, when prolactin is high, it will lead to galactorrhea. It will lead to galactorrhea. So to suppress the galactorrhea, we can use it. Many times what happens, after the delivery of the baby, 3 months later, the mother will have breast milk produced. From the beginning also it is produced. And suddenly she wants to stop the breastfeeding because she had to take some other medicine, and medicine may go in breast milk and the baby may get affected. At that time, what the doctor decides, he decides to stop the breastfeeding, but still the milk comes. So what we do, we give these drugs to stop the breast milk secretion. So there also it is used. The next important thing is these drugs are used in the management of acromegaly. Now, why it is used? There is one important funny thing about this. Now, in normal individuals, the dopamine will not affect the growth hormone. So dopamine has no effect on growth hormone. But in a patient who is acromegaly, who is a patient of acromegaly, dopamine has shown to decrease the growth hormone. So that is the reason why it is useful in acromegaly. Suppose imagine that normal individuals also, if dopamine is high, if their growth hormone decreases, that means no child should be happy, because whenever you are happy, dopamine releases. So that is the paradox here. So normal individual, dopamine doesn't have any effect on growth hormone, but in acromegaly, it has shown to decrease activity of growth hormone. So that's the reason why we use it in acromegaly. Another important use is in the management of Parkinson's disease. Parkinson's disease. So you know that Parkinson's disease is a problem where the activity of dopamine is suppressed. So we need to increase the activity. So we use D2 agonist like bromocriptine and cabergoline. So these are the uses. Let me summarize: prolactinoma, hyperprolactinemia condition, infertility cases due to hyperprolactinemia, galactorrhea, or you want to stop the breast milk, acromegaly condition, and Parkinson's disease. Apart from that, the drug bromocriptine is also approved for one more condition, and that is diabetes type 2. So we'll discuss that concept when I discuss diabetes in the future videos. Okay, so that is about the prolactin inhibitory hormone, that is dopamine. The next hormone what we